from the American Academy of Pediatrics.
Protecting the health of children might start within our clinic walls, but that's not where it ends.
New AAP policy highlights the importance of the physical spaces our families encounter every day.
Families live in systems, and one system could be labeled the built environment, the places where they live, work, and play, that may constrain their ability to follow even the most well-articulated advice from their doctor.
Plus, research in the journal Pediatrics recommends changes to the Neonatal Resuscitation Program.
Really, there's a skill level to using a face mask and providing PPV as well. So in some situations, it may actually be reasonable to use a supraglottic airway instead of a face mask.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. Joanna Parga-Belinkie.
And I'm Dr. David Hill. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a conversation about how the infrastructure around us affects our health.
Joanna, what if I told you that where trees were planted a century ago determines who comes into your neonatal ICU today?
I think I know where you're going with this, but I'd have to ask a few follow-up questions.
Yeah, fair. I do too. But it's not just about trees. It's about highways, parks, sewer lines, the electric grid, schools, sidewalks, even the very hospital and university where you work. They all impact child health, even rates of preterm birth.
You mentioned so many things, David, things we might have no control over in our pediatric offices. Or do we? I think we still need to know more. So let's talk to Dr. Michelle White, one of the authors of a new policy statement and technical report entitled The Built Environment and Pediatric Health.
Dr. White is Assistant Professor of Pediatrics and Hospital Medicine at Duke University School of Medicine, Associate Director of the Duke Pediatric Research Scholars Program for Physician Scientist Development, and Assistant Professor in Population Health Sciences. Michelle, welcome.
Thank you so much. I'm so glad to join you all. I'm a big fan of this podcast, and it's an honor, really, to be able to speak with you today.
Thanks so much, and thanks for listening. And we thought we'd start with you today about the term built environment. What does that mean?
So the built environment is kind of a fancy word for all of the man-made aspects of our environment. It's the places where we eat, play, go to school, work. And then it also encompasses the resources like electricity, water, and sewer structures that provide the resources that allow us to do the things that we love to do and the things that we have to do.
And could you talk about some of the ways that structural racism has influenced community design over the decades?
So unfortunately, our neighborhoods and the community design that we see around us is a product of many historical factors. Among those is redlining, which is a system of policies during the 20th century that led to restrictions on where people could live. There were policies that restricted where particularly people of color, particularly African Americans, could live, who could receive home loans, and who would even be welcome in certain places. And these are some of the roots of some of our current most persistent health disparities. So during that time, certain groups were forbidden to live in places that may be more advantageous in terms of the community structures. There were highways that were built through the neighborhoods of families of color. And that directly now links to exposure to air pollution and asthma hospital admission rates and asthma exacerbation rates. There was also systemic disinvestment in communities of color that even continues to this day because those communities were not, for policy reasons, able to accumulate wealth in the manner that other communities are able to accumulate wealth. For example, how much your house appreciates over time is a primary way in which people gain wealth. And so that was denied to communities of color. And thus, now we are in a system that has, from a built environment standpoint, built-in advantages for majority white neighborhoods that have certain levels of wealth, and built-in disadvantage for communities of color, including Black and Hispanic neighborhoods who have been denied more modernized infrastructures as well as green spaces, access to tree canopies. And now we're seeing, and we have been seeing, the downstream effects of those historical decisions that were made in redlining and other processes.
And when I hear the words built environment, my mind goes immediately to urban areas. But do your reports also include discussion on rural community design?
We do. Not as much as I would have liked. I was a child in a rural environment. I grew up on my family's farm. And I always like to say that 1 in every 5 children in the United States lives in a rural environment. However, we don't have as much research in rural environments as we do in urban environments, and that limits what we can state in this policy statement and technical report. We do know that there are certain health disparities, particularly access to care, that affect rural children to a greater degree than urban children, just due to lack of having a pediatrician in your county or in your area, lack of additional resources, including home nursing, rehab facilities, mental health facilities in rural environments. So we certainly know that there is a need for more research there, and we know that there are disparities.
And just listening to you talk, Michelle, there are obviously so many pieces to this puzzle. For example, also David mentioned trees. You mentioned the tree canopy and planting trees. So let's start with just that. Where are trees? Why do we care about where they are? And what about other plants as well?
Yeah. So trees are important to child health for several reasons. I'll start maybe with an unexpected one. There are studies showing that children that have access to trees and greenery have less stress, and there are mental health benefits. There are even studies to show that there are benefits to school performance, to being around trees and elements of nature. Another aspect of trees that is really important for the health of children is shielding from heat. Climate change is a key topic that we do cover in both of our technical report and our policy statement, and because it directly relates to the built environment, in that trees are part of the structures around us that help to shield us from increasing heat and heat exposure, which can, of course, cause illness. So trees are also important as a part of climate resilient infrastructure, or a way that we can essentially beat the heat, particularly as climate change continues and temperatures increase. So where are trees? That's a really interesting aspect of your question. And it also, unfortunately, relates back to, the fact that not all children have access to some of the more advantageous components of the built environment. And trees are unfortunately the same story as many other key attributes of the built environment relevant to child health. There are studies showing that in neighborhoods of color, there isn't as much greenery and there's less tree canopy and tree covering, which in combination with urban features such as pavement and asphalt can really lead to higher temperatures in communities where children of color live and play in particular. So trees are an amazing resource, but they're not equitably distributed in terms of our community design.
And when we think about other things affecting communities, I know that the report focuses on things like air and water quality. How do those play into children's health?
Yeah, so air is all around us. It's something we don't even notice until something goes awry, right? So having poor air quality can lead directly to asthma exacerbations, as well as predispose you to respiratory infections. So infections like pneumonia, as well as upper respiratory infections. Poor air quality can also be really injurious to children who have chronic illnesses and lead to hospitalization and missed school for those kids as well. And air is relevant to the built environment because we, as humans who drive cars and operate various other equipment, that alters the quality of our air. So one of the key factors related to child health is traffic-related air pollution. living in neighborhoods where there are highways nearby or where there may be buses that idle, that can really make the air quality significantly poorer than living in an area where those features are not in place. So what we talk about a bit in our policy statement and technical report is just the importance of reducing car idling, as well as reducing even the use of cars and promoting public transportation to help minimize the effect of traffic-related air pollution. And in particular, as I noted a bit earlier, traffic-related air pollution is unfortunately another factor that disproportionately affects communities of color, because there are highways that were specifically built through those communities, leading to greater exposure for those children. And water, again, another key essential element for life and thriving. Water quality in most cities is directly related to the infrastructure, including the age of pipes and whether pipes contain lead and other materials. So it's essential that we have updated infrastructure that minimizes the risk of contamination from chemicals and lead. Another element where water is becoming, if it's possible for water to be more important, I don't know, but the flooding that has occurred more and more with climate change has really opened eyes to the fact that, water can be great in its proper place and element, but when it's overflowing in your home or serving as an environment for waterborne illness to invade water that you might drink, then it becomes quite dangerous. So that's another thing that I think we unfortunately don't think about until it's really a problem. But it has been increasing flooding over the last few years, and the influence of flooding on the incidence of waterborne illness for children, as well as the influence of outdated water infrastructure, I think is going to become more and more of an issue in the coming years.
I'm so glad that you mentioned flooding because, as you know, here in North Carolina, we are in Hurricane Alley. And I've seen the difference that it makes in my neighborhood to have good drainage and underground electrical cables. How should we be thinking about climate change in community planning?
So I think that we need to essentially be thinking that potentially, I'm an optimist, so I hate to say this, but potentially the worst is yet to come. So we are seeing an increase in severity of storms, including hurricanes and tornadoes. And so how do we develop infrastructure that is resilient to those stressors? So when we think about flooding, one element of infrastructure that can help with flooding is having less impervious surfaces. So less asphalt and more greenery, more surfaces that are built to absorb water versus just allow water to run off and overflow. How can we ensure that sources of drinking water are protected against infiltration from pathogens or from sewage or from chemicals? So those are some of the things from a water standpoint to certainly be thinking about. Another key element, very relevant to child health, particularly if you have a child with a complex chronic condition like many of our patients who are technology dependent, is the electrical grid. How do we ensure that the electrical grid is resilient to these dramatic climactic events that will probably continue to occur over the next few years? So just ensuring that there are safe methods of ensuring that electricity is delivered to homes, particularly the homes of children who are dependent on technology to live.
So my husband, Danny, and I love to walk or bike our kids to school and back. We live in the city in Philadelphia. Does this sort of thing help with climate change, and how does it affect community building and involvement?
Yeah. So first of all, that's a wonderful practice that you all have. I myself enjoy biking and walking as much as I can. So I would like to say for sure that definitely does help in some ways with climate change, because if one person is making a decision not to use a vehicle, then that certainly is a step in the right direction, to really see kind of a larger or greater impact, we need more individuals and families to make the same choices that your family is making to use active transit or transit that's powered not by an engine, but by your body. And so in order to do that, though, a lot of folks live in places that don't have safe structures that make walking and biking safe and pleasant. So one of the key factors that allow particularly families with children to feel comfortable is having complete streets, which is the presence of sidewalks that are a reasonable size that allow individuals with different forms of mobility to get on the sidewalk. So having that cut out that you may not notice if you are able to be mobile without any assistance. But for those of us that rely on wheelchairs or any sort of device that might assist us in our ambulation and our mobility, those cutouts are really very, very helpful. Other features that make biking better and safer include having well-marked bike paths that are separate from the roads, having an actual physical barrier, as well as having really well-marked crosswalks with signage that individuals can read or hear easily, regardless of how they may communicate. So those features are not present everywhere. They're growing. The number of cities that have complete streets programs is increasing, thankfully, but not yet to the point where every family can safely walk to work or to school or to the store. If we get to the point where families are able to make those choices because those structures are more supportive of those behaviors, then I think we'll see much less traffic-related air pollution and less air pollution in general, just given the fact that more of us can really safely make those types of choices. Also, there are added benefits for our physical activity too. Childhood obesity remains a significant issue for many children and families. And so being able to use active transit, walking or biking, can really be helpful for keeping our bodies healthy and our weight healthy as well.
Can you talk about the placement of institutions like libraries, universities, hospitals, even the community health center where I work?
So these are amazing resources for communities. Libraries, one of my favorite places to go in my community, are not only places to check out kind of the next bestseller, but they're also places where you can have free or low-cost work training sessions, education, opportunities to do art classes. Like these are really our modern-day community hubs. And they are accessible to anyone in the community, which is really essential when you think about equity. Hospitals are also extremely important resources for us. And I say that not just because I'm a pediatric hospitalist, but also because hospitals are what we call kind of anchor institutions. Hospitals serve the community not just through medical care, although that's really key. Hospitals have the potential to also serve the community by investing in the surrounding community, being a source of work and career development for individuals who live in local communities, as well as hospitals have the opportunity to invest in surrounding community structures and businesses. There are some hospitals nationwide that have elected to invest in housing for low-income individuals and families. So hospitals really have this opportunity to give back in a way that's not just biomedical in origin. And I think that one of the things that's important for us as pediatricians is to really advocate for our hospitals and health systems to be the type of hospital or health system that gives back to the community, not just in terms of medical care, but in terms of housing, education, providing work and income for individuals in the community who may not have the same advantages as other groups.
Michelle, this is such a huge topic. I fear pediatricians will think it's too much for them to tackle. Do you have any last takeaways before people read these reports?
Yes, that's such a wonderful question. This can be incredibly overwhelming because a lot of us as pediatricians may only have 15 minutes to address all the things that we need to address. And now we're adding the built environment on top of it. And it's not meant to be that way. I think the number one thing that I would highlight here is our policy statement is really a call for pediatricians to meet families where they are, to recognize that families live in systems, and one system could be labeled the built environment, the places where they live, work, and play, that may constrain their ability to follow even the most well-articulated advice from their doctor. One of the areas where this is most commonly felt is when we're giving counseling about physical activity and eating healthy. Some families don't have access to safe places to play. And some families may not have access to grocery stores that sell less processed goods, that sell fresh fruits and vegetables. So making sure that when we counsel families, we recognize that some of the choices that families are making those choices are not just the product of kind of families, kind of what they want to do. Some of it's what they have to do because of the places in which they live. So one solution to this is to become more well-versed in the community resources in your particular community. If a family does not have a safe place to play or be physically active, are there programs that you could recommend that create a safe indoor environment, potentially after school, for a child to go to play or to hang out as a family and be active together? There are many communities that have shared use agreements with schools that allow the school to be open after normal school hours as a safe place to be active. So being aware of those community resources. Are there corner stores that have fresh produce programs that you could refer families to? So I think that's the most important thing, is just being aware of how important the environmental context is to how families behave and child health outcomes in general. Another key element for pediatricians that I want to convey is the importance of advocacy. For those who are able, there's a lot of room for additional advocates here with regard to how communities are designed. I think there has been an awakening over the past 10 or so years in the importance of built environment and community design. And so attending meetings with community leaders, with legislatures to ensure that the voice of children is heard, and the voice of children might very well be you as a pediatrician. So advocating for changes that are relevant to community health and just ensuring that all kids have access to some of the resources and advantageous components of the built environment, such as complete streets and access to parks and playgrounds that are safe and well designed, as well as some of the climate resilient infrastructure elements that we've also discussed. So there's a real advocacy role there for pediatricians who are interested in doing kind of broader community and citywide advocacy. Really elevating perspectives, particularly those perspectives that might be marginalized all too often. That's a really, really important aspect of ensuring that community design is healthy for all children.
Well, Dr. Michelle White, thank you so much for giving us your presence and your voice for this podcast today.
Thank you so much. This has been such a pleasure.
To read the policy statement and technical report, The Built Environment in Pediatric Health, go to aap.org/podcast.
Coming up, we'll look at suggested changes to the Neonatal Resuscitation Program. David, we both have things we get hung up on, and one of mine is how critical the first few minutes of life are for babies in the delivery room. We follow the Neonatal Resuscitation Program guidelines to a T because we don't want to miss any precious seconds that can save a baby's life.
Well, this is a great conversation because I have to recertify in Neonatal Resuscitation Protocol this month. And as a hospitalist, I go to delivery rooms all the time. I'm always reviewing the poster on the wall and my little pocket card because I never want to have to call one of your colleagues, Joanna, if I can help it.
And even though it would put us out of a job, all neonatologists want is for babies to be healthy and thrive. So I'm so glad today on the podcast we get to focus on some recommended changes to NRP that came out in 2023.
Wait, changes? You heard I have to recertify, right? Okay, then let's chat. And while we already have one neonatologist on the show, let's invite another, Dr. Henry Lee, one of the authors on a paper in Pediatrics, 2023 American Heart Association and American Academy of Pediatrics focused update on neonatal resuscitation, an update to the American Heart Association guidelines for cardiopulmonary resuscitation and emergency cardiovascular care.
Dr. Henry Lee is a professor of pediatrics and medical director of the NICU at Jacobs Medical Center at UC San Diego Health. He's also a member of the AAP section on neonatal perinatal medicine. Henry, welcome to the show.
Thank you, Joanna. Thank you, David, for having me on. Yeah, it's a real pleasure to be able to participate.
When NRP guidelines change, it's not without a lot of fanfare and tremendous review of the evidence base. What was the process for coming up with these suggested changes?
The 2023 update that you referred to isn't actually a change to the NRP guidelines. As you spoke out that long title of that article, it's an update from the American Heart Association and American Academy of Pediatrics writing group for neonatal guidelines. However, that is not necessarily translated quite yet to the Neonatal Resuscitation Program, the NRP. So,
does that mean it won't be on my test, Henry?
It actually won't be on your test. Yeah, that's right. Because NRP is, the program does use the AHA AAP update, but we're sort of not quite there yet. The AHA-AAP update relies on this other group called the International Liaison Committee on Resuscitation, or abbreviated ILCOR, which reviews the scientific evidence on neonatal resuscitation on a continuing basis. So there's a group of folks from around the world, actually, who are reviewing all the new studies that are coming out and trying to discern what's the best evidence, doing systematic reviews and meta-analyses. And based on that, they make recommendations. And the American Heart Association and the American Academy of Pediatrics come together as a group. And this group then looks at what ILCOR has put out and see how does this apply to the North American, healthcare community, and how can we best apply this to newborns who might need our help in North America. And so because ILCOR had come up with some recent evidence, this group, then we decided to publish this update. Now, NRP is actually updated about every 5 years. So the NRP currently is in the phase of the 2020 NRP guidelines. And so the 2025 NRP is going to potentially use the 2023 update to update the program.
And this report highlights some recommendations that to me were kind of 4 shifts in thinking with resuscitation. So let's walk through each one, starting with umbilical cord management. I know our listeners are likely familiar with delayed cord clamping, but what is cord milking?
Yeah, no, that's a great question. The concept of umbilical cord milking is really sort of related to the principle of what we might call delayed cord clamping or deferred cord clamping, where we're allowing a further placental transfusion to allow for the baby to receive a little bit more of the blood from the placenta prior to the cord being clamped. So in some cases, there may be some reason why you can't defer the cord clamping for the desired period of time, in which case, if you milk the cord by the obstetrician using their fingers to sort of milk, as you might consider what it looks like to milk, a cow when they're milking a cow, to allow some of that blood to then transfuse into the baby and then clamping the cord.
And just to get a little granular with this, what kind of evidence informed these decisions about clamping or milking?
So there's a lot of process in reviewing the studies that have been done by researchers really around the world in this area. And there's been a lot of interest in umbilical cord management over the years in this past decade. And there have been studies on umbilical cord milking as well as delayed cord clamping. And the randomized controlled trials ultimately informed the evidence. So this body, the International Liaison Committee on Resuscitation, ILCOR, reviews all of the studies and performs systematic reviews and meta-analyses. And ultimately that informs the evidence that goes into the guidelines.
And when we're in the delivery room, how should we determine who should get delayed cord clamping versus this milking process?
Yeah, so in most situations, the preferred process is delayed cord clamping or deferred cord clamping. And in most cases, that's possible, both in term and preterm infants. The studies and recommendations are really sort of parsed out into preterm and term recommendations because that's how the studies tended to be done. And the outcomes are really sort of different for those populations. And in preterm infants who are going to be in the neonatal intensive care unit, for sure, if they're below a certain gestational age, it's been shown that there are certain interventions that may be reduced because of the process of delayed cord clamping, for example, like blood transfusions and the need for other medications like pressors potentially. And even survival is improved when we look at the evidence for delayed cord clamping. The process of cord milking really is meant to be sort of an exception, and in very preterm infants, it's actually contraindicated because there has been harm shown from umbilical cord milking for babies that are born before 28 weeks gestational age. And so the recommendation that the update is informing is really in a very specific population of babies who are non-vigorous and 35 weeks gestation or older.
And getting into the delivery room more, I always tell my trainees, don't stress about intubation because it's positive pressure ventilation that saves lives. What does this report say about the preferred method of delivering positive pressure ventilation, or PPV?
Yeah, so the previous American Heart Association guidelines talked a lot about PPV or positive pressure ventilation because it really is the key sort of intervention for babies who are needing our help in the delivery room. However, the guidelines did not really go into what devices might be used for PPV because some of the evidence had not yet been published. And so now there have been studies which inform our devices. And one of the devices that we have been using for a while, but it was not necessarily certain whether that's the best device, but it does seem from the evidence, and we concluded that the T-piece resuscitator is preferable to a self-inflating bag to administer PPV. And definitely for preterm infants, it's beneficial in terms of the ability to control the pressure and potentially reduce harm.
I'm so glad we're talking about intubation and alternatives because honestly, when it comes to intubating newborns, my entire year is equal to about Joanna's Tuesday morning. So are there other alternative airways we should consider to secure the airway during resuscitations?
Yeah, so thanks for asking that question. One of the recommendations from the update concerned supraglottic airways, which are also sometimes known as laryngeal mask airways, which are an alternative to intubation and likely to be potentially easier for those of us who might not be performing intubations on a daily basis. The skill level is such that the supraglottic airway can be performed by a variety of healthcare professionals, and also those, again, who might not have the experience or maintenance of skills for intubation. And so the studies have shown that this can be used as a primary interface to administer positive pressure ventilation, and potentially could even be used instead of a face mask. Sometimes it's thought that, a face mask has been traditionally what we use initially when we provide PPV. And so there's maybe an assumption that it's the most effective or easiest to use. But really, there's a skill level to using a face mask and providing PPV as well. So in some situations, it may actually be reasonable to use a supraglottic airway, even instead of a face mask.
I can see that as a big change in the delivery room. And your paper in Pediatrics is concise with helpful bullet points for changes. So everyone who spends time going to deliveries should really read it. Do you have any last takeaways about these 2023 recommendations before we let you go, Henry?
Yeah, so no, I appreciate that the update hopefully can inform everyone's practice. In all of these things, there's a team sort of environment in which these things need to be implemented. So, when someone reads these guidelines and this update, it's not really possible for you to decide on your own, I'm going to start doing this in my practice. Really, it has to be in the context of the team. And so I think I would hope that teams and hospitals and neonatal units would read this together and decide, how can this maybe inform our practice together, and perhaps implement some protocols to try to learn together and see if this might be useful in their team practice.
Well, that has been so useful, I know, to me, and I hope to both of us. Dr. Henry Lee, thank you so much for joining us today.
Thank you so much for having me on. Appreciate it.
To read the 2023 American Heart Association and American Academy of Pediatrics focused update on neonatal resuscitation, an update to the American Heart Association guidelines for cardiopulmonary resuscitation and emergency cardiovascular care, visit our website at aap.org/podcast.
At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, mine is work-related. I've never actually done a telehealth visit before this week, Joanna. But when I was in clinic...
Really? Wow.
Yeah. Just, most of my time is spent in hospital medicine, so everybody's where I am. But I was in clinic this week, and I got to do a telehealth visit with the most adorable little 6-year-old boy. And because we were on telehealth, he was able to show me his entire collection of toy dinosaurs and the indoor swing that he gets to play on in his house. And we're asking about his illness, but also meeting all the dinosaurs. And it was just the funnest thing in the world. And so I hope I get to do that again.
That's so adorable. And my Say Ah is pretty adorable as well. And that's that my newborn baby is over a month old. So yay.
Ooh,
that's a milestone. And she's gaining great weight. And I've been able to so far exclusively breastfeed her, which I'm really proud about.
Oh, that is great.
It's really nice when they grow and you're providing the milk and it's a good feeling.
I cannot even imagine what a great feeling that must be. I am just so happy for you and Zelda right now.
Thank you.
That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll talk about overuse injuries and burnout in youth sports.
We'll speak with the authors of a new clinical report, Drs. Joel Brenner and Drew Watson. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.